Hi, everyone. My name is Philippe Lallier. I'm an interventional cardiologist here at the Montreal Heart Institute. I would like to wish you a very warm welcome to the Montreal Heart Institute Cath Labs. I'm here today to discuss a case entitled the Multivessel Disease PCI in the context of STEMI. It is a pragmatic approach that we have here at the Montreal Heart Institute. It's not necessarily institutional, but we do it basically fairly similarly all together as a group. I would like to introduce my colleague. She's a fellow.
Yeah, so I'm Jamina Dulub, interventional fellow from Bristol, UK.
And I have a wonderful team with me. May I have the first slide, please? So I'm here with Marilyn Champagne at the imaging tech, Karine Blais-Delaurier, who's scrub with me, Véronique Massicotte, who is the nurse at the cath lab, and Sandy Boucher, who is going to be helping us with the equipment. So next slide, please. So we have a gentleman here who came 2 days ago with STEMI of the inferior wall. The patient had a totally occluded right coronary artery. So we have no
Next
potential
slide,
conflicts for this patient. And the patient had a history of dyslipidemia, mild dyslipidemia. Angiogram demonstrated occluded RCA, which was the culprit of the STEMI, and diffuse multifocal disease and calcified lesions in the left system. May I have the next slide, please? So this is the schematic diagram of the anatomy. So very complex disease globally. May I have the next slide, please? And this is what we did for the RCA. So calcified disease occluded in the mid segment. We recanalized it. We use the technique when it's calcified and it's acute when we don't necessarily want to image immediately. We use a non-compliant balloon with a 1-to-1 balloon to artery ratio, and then use orthogonal projection to make sure the balloon is fully inflated. And then if this is the case, we continue on to stenting. And we finally had a very good result in this particular RCA that you see on the right panel. May I have the next slide, please? So now the question is what to do with the complex lesion on the left system. There are multiple ways to address this question. And of course, we will discuss this in the next few minutes with you guys. May I have the next slide, please? So there are a number of alternatives. We can use this strictly angio. This has been validated in the past, where we had a number of studies, which is the Dynami, Primulti, Compare Acute, and Complete, which were mainly angiography-guided PCIs of severe lesions. Severe lesions vary from study to study, from 50% angiographically evaluated by eyeballing, or 70%, depending on the study. And if it's severe, you continue on to proceed with revascularization, and it has been demonstrated to reduce clinical events at the follow-up. Of course, alternatively, we can also use physiology to more precise evaluation of residual stenosis. And this can be done safely during the acute procedure or as a staged procedure, either within the same hospitalization or within 6 weeks, for example. So this is the results of the FRAME AMI study. There is at least a 50 or 60% of the patients who actually came in with acute STEMIs that have multiple vessel disease. And in this particular study, FRAME AMI used physiology, and 60% of patients had a median PCI during the intervention. 40% had a stage PCI during the index hospitalization, and this has been associated with a 67% reduction in clinical events at 3.5 years. This is probably the best results we have, and this is the latest study in this context. The largest one would be Complete, and the Complete trial was mostly done as a Canadian study. They use basically angiography to guide PCI for severe lesions, and physiology if the lesion was between 50 and 70%, but 70% was the angiographic cut point to do a revascularization based on angiography. So may I have the next slide, please? So in our particular case here, I would just like to let Dr. Dulub here discuss a little bit what OCT can actually, how it can be used to
Yeah, so this was an interesting sub-study of one of the landmark studies that Dr. Lallier has mentioned, the Complete study. So in this, they basically looked at all the patients from Complete undergoing OCT, intravascular imaging. And the interesting thing is that they found that 47% of patients, and nearly half of those patients who had at least one obstructive non-culprit lesion were found on OCT to have thin cap fibroathyroma. Now, we know that thin cap fibroathyroma is a sign of a vulnerable plaque. It's an indicator of plaque rupture, and perhaps that explains to some extent the impact that we have when we see that, patients who have full revascularization after their STEMI do better in terms of outcomes, so MI and cardiac death, that we've seen in complete and culprit trials as well. So there's a fair correlation between your angiographic obstructive views and signs of vulnerable plaque, which is quite interesting.
Okay, so may I have the next slide, please? So as far as the clinical algorithm, for the non-infarct related artery lesions, we suggest that we go by angiographic severity. If it is intermediate, we definitely promote IFR, FFR guided PCI for those lesions. If it is clearly severe, we promote angiographic imaging guided PCI. And if it is a CTO, this is a special consideration, but we promote default OMT to start with. So normally here at the Heart Institute, the non-infarct related artery are typically performed as a stage procedure during the index hospitalization. And this is the case for this patient. As I mentioned before, this patient came in with a STEMI about 2 days ago, so 48 hours ago. Mm-hmm. And now we're planning on doing an angioplasty. So may I have the next slide, please? So now we will switch to today's angiography. Mm-hmm. May I have today's angiogram? So first image of the right coronary artery. Peux-tu montrer la droite, s'il te plaît, en premier? So here's an indication of the right coronary, the approach for the vascular access is radial. It is sometimes fairly complex. We have a very severe bend in the radial artery, but we definitely use the standard BNW, mm-hmm. and we were able to go through this bend and up with the diagnostic catheter and exchanges for an 035 wire without difficulties. May I have the next slide, please? The next image, please. La prochaine, s'il vous plaît, pour la droite. Tu me montrer la droite, s'il te plaît? Non, la coronaire droite. On la voit pas.
Yeah.
Okay. So here's the. Parfait, merci. Les images d'aujourd'hui, s'il vous plaît.
Yeah.
Okay, so this is the result of the RCA. It remains a good result from in the proximal part where it was actually stented. We have still some diffuse disease in the PDA, but this was not addressed and will not be addressed as of now. You have the next image, please, la prochaine séquence. So this is the left system, which is the target for today. We have very severely calcified lesions, both in the marginal branch and the marginal branches, I should say, distal circumflex. We also have LAD, which is severely calcified. We can definitely see it by looking at the angio. It is also some ectasia, so very complex disease. Prochaine projection, s'il vous plaît. So we have an extremely tight lesion of DLAD after the diagonal branch. It is also severely calcified, again with some ectasia. Prochaine diapo, s'il vous plaît. Prochaine run, s'il vous plaît. So you can also appreciate that the diagonal branch is also severely diseased and narrowed. Prochaine run, s'il vous plaît. Prochaine run. So our evaluation is that most of these lesions would be more than 70% angiographically speaking by eyeballing. So we would perform immediate angioplasty of the LAD and diagonal and the distal marginal. But we would also evaluate the major marginal branch by physiology if we can, because it is not necessarily 70%. So we decided we were going to go ahead and do the angioplasty of the LAD, calcified, very calcified. We wanted to do OCT. So we tried to open the vessel a little bit with a 2.0 non-compliant balloon. And we perforated 2 of these balloons, showing us that this was extremely calcified superficial calcium and could not dilate this. So lithotripsy would not be an alternative as of now. Mm-hmm. So we switched plans. We went to rotablator. So we are going to do a switch from the standard the BMW wire we had in place for the roto wire. We use the roto floppy, and we're going to use a 1.5 burr to actually do this. So we're going to do this live for you, and we're going to perform this, and then we're planning on doing a mini crush procedure, stenting procedure for the diagonal branch. On va changer de place.
Mm-hmm. Maintenant?
So we are using in the RotoFlush is my own recipe. It's been the same recipe for a long time. I use verapamil, nitro, and heparin in the flush. I'm not using RotoFlush. I'm not using the Roto solution because I do believe that we embolize enough. We don't need to embolize fat when we do this procedure. Ça fonctionne pas un petit peu.
Mm-hmm. Ouais.
Okay, je vais juste le tenir dans le vide, s'il te plaît.
Mm-hmm.
So we're going to use the 180 rotations per minute. Okay, c'est bon dans le vide.
Ouais.
Parfait, merci. Go in on Scopy.
Yep.
So as we go in, for those of you who don't do rotoblators so often, neither the guide catheter nor the wire can actually move as we go in. We're using a 1.5 burr. I typically don't go under 1.5. I think it's enough. So Jemina is going slowly. I'm following her. The wire's coming back just a little bit, so I'm going to let it go just a little bit as she goes in, but I'm going to hold it. You cannot maneuver the wire when the system is in place. We should see the burr soon.
It's coming. The wire is coming back.
Okay, hold on for a second.
Yeah.
So now that we have pushed this a little bit, I'm going to just make it go ahead a little bit. Okay, mm-hmm. Advance.
Yeah.
Okay, hold on.
Mm-hmm.
Okay, so I just set it a few times so that we don't have surprise. It doesn't jump. Copy. Okay, so for now, I think it's, I prefer myself to do something different than most. I most prefer the pecking technique. I prefer to slowly oppose the burr to the lesion and go slowly in a controlled fashion through the lesion. This is what happened here. It went fairly well, no major deceleration, and the first pass went through nicely. So now we're going to see if there is a no reflow dissection or something else. C'est ciné ou c'est Scopy?
Scopy.
On va faire ciné, s'il te plaît. Okay.
Yeah. I'm ready.
Vas-y.
Ciné. It's a slow flow.
Scopy ici. OK. Vas-y.
Ciné encore?
Attends, ouais.
OK. La pression.
Correct. Est-ce que c'est le burr?
OK.
Okay, so it looks nice.
Yeah.
So we open it up nicely.
Mm-hmm.
So we're going to remove we had no restriction to the burr, so we're going to go Dynaglide and come back. Is copy. That's it.
OK.
C'était use. Okay.
Oui.
OK, so on va prendre le ballon 2.5 ou passez-moi un 3.0 non compliant, s'il vous plaît. So now we're going to try a non-compliant balloon to see if we can actually crack the lesion. If we cannot, we will use lithotripsy to complete the work. Of course, now that we have, we're quite confident the lithotripsy can actually go in, and we've already done rotoblator. We don't need imaging at this point, just to see whether the balloon expands or not will be enough. This will be the ultimate test. Je vais prendre le BMW, s'il te plaît. On pourra faire ça.
On va échanger.
So we'll do it as elegantly as we can. So we're going to use, again, the microcatheter to make the exchange to the standard PCI wire, which is the BMW, our so-called workhorse wire. 3015, s'il te plaît. OK. Vas-y, je l'ai. Jimena is pushing slowly the microcatheter. We had a lot of difficulty actually bringing it in initially, so we'll see whether it goes in nicely. I'm expecting this fully.
Quite smooth.
So very smooth. Okay, it's fine. So we'll stop there, remove the roto wire, change it for the BMW. Okay, merci. Exchanging the wire to the workhorse wire.
Mm-hmm.
So we'll bring this back.
Yeah.
Now we're going to hydraulic this out. Okay, so when the system is in full equilibrium, we will just make sure that we will remove air, no air in the system, and we will go up to about 14. And this is going to come out. Catch it, please. Okay.
Yeah.
Okay, so maintain it to 14 and it comes out nicely. Okay, we got it. Okay, let's prendre l'autre BMW, s'il vous plaît. We're going to protect the diagonal now because we're planning on inflating balloons now. So we will try to protect the diagonal. Mettre le Y dessus, s'il vous plaît.
Ouais.
Je te place.
Oui, bien sûr.
Un peu de cœur là-dessus, s'il vous plaît. So we're coming in with a second BMW wire to try to position it in the diagonal branch.
Okay.
Want to give me a little test shot, please?
Yep.
A little test.
Mm-hmm.
So of course, somehow this was easy to wire initially. Now it's not so easy, so it can happen. We're going to take enough time to do it.
Yeah.
Je pourrais avoir un guide run through, s'il vous plaît.
Ouais, c'est passé.
Plus
vite. Vous voulez un test?
Oui, s'il vous plaît.
Okay. On est OK pour le run. On n'en a pas besoin. C'est passé. Merci. On est dans la branche, je crois, le test.
Ouais.
Non, c'est bon.
Okay. Okay, so now that the diagonal branch is protected, we will identify this wire by using the torquer, and we will bring down the non-compliant balloon. We use the
3015.
30 to see really well if it's inflated or not. And as I mentioned,
Sorry.
as I mentioned before, we will use orthogonal projections to make sure that this is well open. We're using a non-compliant balloon in order to go up in pressure, make sure this is well open.
Mhm.
So 30,
15.
15
Mhm.
went in nicely, just a little test shot.
Yeah, sure.
So this is exactly where the previous balloons ruptured.
Yeah.
Go on slowly.
Yeah.
We'll go on to 12.
12. It's going up nicely.
Okay.
Yeah.
18.
18. Yeah.
So it's reasonably open. Not entirely sure it's fully open, to be honest, though. 24.
24. That's open.
Yeah, I think that's open. Off.
Off.
Okay, so that's fine. We'll go cine.
Ready?
Okay,
Mhm.
cine.
Yeah.
Okay, well, this went flying. Hein?
Yeah.
Non, c'est trop de pression. Peux-tu baisser ça un peu, s'il te plaît?
Baisse un petit peu à 400 peut-être, s'il te plaît. La pression.
Now that we know that the LED is open, peux-tu montrer la dernière image, s'il te plaît? I think we will tackle the diagonal branch. Prendre un ballon 2-0 NC, s'il vous plaît. Le plus long que vous avez sera le mieux.
Est-ce que vous voulez un ACT?
On va faire la diag avant.
OK.
Est-ce qu'on a un 2-0 non compliant? C'est ce que ça
On
fait.
attend. On attend.
So as you see, these multivessel disease patients are not necessarily always easy to perform, but because they are stage procedure, this is clearly an advantage for us, because if we would have tried to do this during the acute procedure, it would have made things much more complicated. Mm-hmm. And to be fully honest, I don't think it would have been appropriate. So I'm strongly in favor, and I promote whenever possible that we should do stage procedures, because I'm expecting the result on the LAD to be optimal. And I definitely do not want to have a suboptimal result in the LAD. So if I would have done it during the acute procedure, would have made it complex.
So the 2015 is the longest we've got.
No.
Yeah.
So again, because of the calcifications, I'm using non-compliant balloons even to pre-dilate.
Okay. Passed quite nicely. Yeah.
Yeah, went in, and we could feel the calcification. Okay, test.
Yeah.
Veux-tu me montrer veux-tu montrer l'image du début du 1040, s'il te plaît? Going to make sure we're not missing the lesion that we are aiming for. So I think so we need to go a little bit distal to this bifurcation in the middle portion. It's test.
Yeah.
We're going to go up to here. Okay. On. I think we can go up to 20 would be good.
Yeah. 20. Nice.
Okay, well open. This is not severely calcified by the angio. Off. Here is where it is severely calcified though. Okay, on 24.
Good.
I'm not sure it's opening up proximally, yeah?
Yep.
I'm going to keep it up for a little bit, see if it's going to open up more. It's not opening up, huh?
No. It's a calcium.
So we have two options, either go down again with the roto to this branch, but we would need to leave the LED, the LED without a wire, which I don't necessarily like. So we may try to go up with shockwave in the diagonal branch.
A 2.5 shockwave. Off.
On again. Shockwave 2.5, s'il vous plaît.
24.
So there is one resistant lesion that we can see really well here in the lab. I'm not sure if you see it, approximately 2/3 down the balloon. Off.
Off. Oui, s'il te plaît. Okay. We're just getting the shockwave ready.
So once again, when dealing with very calcified lesions, unfortunately, it is very useful to have access to all these technologies, because one technology is not always the right one for every lesion that we need to tackle. In this particular case here, we could have done roto in the diagonal branch, but not after inflating in the LED. I was not expecting this. I'm a little bit caught by surprise. We need to react, and we need to deal with this as best we can.
Yeah. She's just getting it ready. Elle n'a pas encore préparé. Thank you.
So this technology, again, with the shockwave, is lithotripsy. It's, of course, a very useful technique. Once again, does not work in all cases that you would like it to work, but we're going to see if it's going to do what it's supposed to do, and that is cracking the resistant lesion in the proximal diagonal branch.
Yep. We'll just need to connect, and then we can inflate.
So once again, we need to connect the system, make sure it's functional, and then we go in. It goes by bursts of 10 shocks. We can go up to 8 runs of 10 shocks, so 80 shocks total.
Okay.
I tend to go to a slightly larger balloon to artery ratios with the shockwave balloon. In the sense that whenever you use a too small a balloon, you run the risk of not being able to perform the actual fracturing of the calcium. So my experience is that you need to go with slightly larger balloons rather than smaller balloons.
I have it.
C'est bon? Ça a l'air bien?
Bon.
Oui? Okay, the profile of this balloon, of course, is by no means the best you will ever see. So it would be interesting to see if we can slide this in the diagonal branch. So coming in.
Il faudra avancer un petit peu.
De résistance. Ouais, on est obligé d'avancer plus parce qu'on ne se rend pas.
Okay, thanks, Tom.
So ACT is 296. We appreciate that. We like it to be as high as possible. Est-ce que vous pouvez peut-être lever la machine de shockwave puis la glisser par-dessus le... Ouais, on est pas proche là.
Non, elle va déconnecter puis elle va se reconnecter.
Ça, c'est contaminé ici. Passe-le par-dessus, s'il te plaît.
Le dessus.
Et c'est contaminé, OK? Be careful. It's plastic. Yeah.
C'est coupé.
OK.
Oui.
Ça ici, s'il te plaît.
Ouais.
Okay, so it was actually put into position nicely. J'aurais besoin de voir les images du.
Okay.
Okay.
On peut tourner ça, s'il te plaît? Le shockwave, là.
Okay. Go on to.
4.
Go to 6.
Yeah.
Okay. So we're up. So we're giving the treatment right now. Seems to be well open.
Yeah.
I think so, yes. We'll go a little bit further down the vessel.
Do you want me to?
Yeah, off. Okay. Inflate again.
Yeah, 6.
Seems like it's opened up again nicely at this point. Off. So much better than our previous.
Better, yeah, for sure.
So we're sort of happy with that. A little bit further down again, if we can.
The wires.
Yeah, so some resistance here, of course. Okay, on. On it, 6, on. Off. So it seems that the resistant lesion is a bit more proximal. So we're trying to be careful while pulling that the wire does not go too far down.
Yeah.
Same with the guiding catheter. Okay, on 6 again. When we're going to use all the, even 8 if you can. Increase a bit the pressure to 10.
Okay.
That's nicely open. Off. Okay, so we will see what this looks like angiographically. Why don't you go up here a little bit in the LAD?
10?
Yeah. And yeah, we're going to give the shocks.
Okay.
Nicely open.
Thank you.
So I'm going to give a little bit of nitro to see what it looks like. So for those of you who know me, I'm a big fan of nitro because I think it's part of the angiogram. We need to neutralize the vasomotor tone, which is quite often a significant issue, especially in the acute STEMI setting. Of course, now it's not the acute setting, but it's still recent. So we're going to try to see if we can have
Yeah. A bit of a dissection in the middle.
Yeah. Okay, so our goal now will be to stent the diagonal first, because I don't think I can actually come in with a stent in the distal in the diagonal branch afterwards. So I'm going to use a 2.0 by a 2.0 stent. So I'm going to use Onyx 2.0. Est-ce qu'on a 2.0 le plus long qu'on a? Qu'est-ce que c'est? Un 30, s'il te plaît. We'll use a 2030 Onyx stent. a very nicely flexible stent. It performs really well.
Mm-hmm.
So we're going to see if it goes through the midsection of this diagonal branch, which we had difficulty, but it certainly looks more open than it was before.
To 0.30. Merci.
So this one done very nicely. Test. Perfect.
Not bad, yeah.
Now we need to choose the actual projection that will show us the best possible projection to see the origin of the ostum of the diagonal branch. On va aller en OAG, s'il te plaît. Plus en OAG, comme 30. Et plus vers la tête, hein? Ouais. Ouais, OK, c'est bon. Ouais.
Mm-hmm.
OK, c'est fini. I'm going to use a little bit more test.
Yeah.
Okay, fini.
Mm-hmm.
Okay, my goal here, my strategy and technique would be the mini crush stent. So we're going to go up now.
Mm-hmm.
Go up to maybe
12.
Yeah, 12 is fine. So to me, it looks nicely open.
Yeah.
Okay, off. Now go back a little bit up in the LAD. On 18, please.
Mm-hmm.
Remember, this is a 2.0 stent, so at 18 atmospheres.
Mm-hmm. 18.
Okay,
Mm-hmm.
off. Okay, so I'm going to leave this balloon inside the stent in order to allow me to come down in the LAD with a non-compliant balloon. Je vais prendre un 3.0 par 15 ou 20 de long, s'il vous plaît, non compliant. 9, s'il vous plaît, je voudrais avoir un nouveau. And the goal here would be to advance an uncompliant balloon. If we are in place, we're going to remove the wire from the diagonal branch, crush the stent, come down with the LAD stent,
Mm-hmm.
and then do pot technique, rewire, and then going and performing a final kissing inflation and a pot technique at the very end for the proximal AD.
Mm-hmm.
The balloon left inside the stent will help us to try to maneuver around the strut of the diagonal branch that may be sticking out, or hopefully sticking out a little bit in the LAD. But we're going to leave this in a neutral position, and then we're going to go in with the non-compliant balloon in the LAD and see how it behaves.
We'll just need another inflate. Not an gonfle.
So it went in nicely. So now that we are in with
We're waiting for
the LED balloon, we will remove the diagonal wire and the diagonal balloon. Because we do not want to crush wire inside the stent.
Mm-hmm.
Okay, a little test here. OK, je vais te prendre un ballon, un stent plutôt, 3,0 par 48, s'il vous plaît. So we're going to use a very long stent. We have 48 synergy stent. This is what we're going to try to get in place. We'll see if we have the... Okay, so we're happy with what we see for now.
Yep.
De 75-48, c'est bon. So we had seen a distal LED dissection, or mid LED dissection. Est-ce que je peux avoir la dernière photo de dernier ciné de l'IVA?